Greetings and thank you for joining us. I'm Dr. David Sears, current member of the Board of Directors of ASPEN, fellow of ASPEN, and recently retired from Columbia University Medical Center as professor of medicine. With me is my dear friend Phil Ayers. He's clinical manager of the Department of Pharmacy, Mississippi Baptist Medical Center, a clinical associate professor of the University of Mississippi School of Pharmacy, former president of ASPEN, and he and I have served on the PN Safety Committee for most of the last, about 25 years, Phil?
That's about right.
Yeah, so we
Yeah.
know each other well and can almost finish each other's sentences. But we're here to talk about a new paper that has just come out, which is an important survey of practice. Phil, why don't you introduce the paper and tell us why it's important?
Well, thank you, Dave. It's great to be with you. I appreciate the opportunity to be here and the opportunity to talk about this paper. So this is the 2026 PN Parental Nutrition Survey and Gap Analysis. And this is really the third iteration of a PN survey. Dr. Sears actually led the first one in 2003. And then there was one led by Dr. Joe Bellotta in 2011. So this is our third survey done for PN. So this is really important because we're looking at, ASPEN guidelines, whether people are following our guidelines and recommendations, looking at changes in practice. And we've used these at ASPEN for a number of years to review, to update guidelines, to make sure things are up to date, kind of get a feel for what's actually happening in practice. So they're very useful to ASPEN as an organization and to the PN committee as well. We've used these to create educational material that we've not only presented at ASPEN, but other national and state meetings as well. So these are very well utilized by the organization and also clinicians too, when they're looking at their own practice and comparing to what other people are doing. So very important. And I really appreciate the opportunity to be with you and to talk about this. This has been a great experience for me working through this and going back and even looking at your original survey in 2003 and how much we've gained from that and the 2011 now 2026. So they've been very helpful in terms of formulating the future for Aspen.
That's great. Can you give us a sense of how a survey like this actually comes about? What are the steps in creating the questions and maybe something about the validation?
Sure. So we go back and we look at previous surveys. And so we went back to 2003, then 2011, looked at those questions. And so we had an interprofessional group that reviewed those questions and see if those questions were still valid, and then updated those maybe to what we're doing in terms of current practice, in terms of recent guidelines, recommendations, position papers that have been published by Aspen. So reviewing those using an interprofessional group is just, very important. We also validated those questions within the group as well. So it's important. And this time with this survey, we actually used a survey methodologist, which was very helpful in, creating the survey, making sure the survey flowed, making sure the questions were appropriate. And with this survey, there were sections of this survey that maybe were only answered by pharmacists because they were more compounding related than maybe another discipline would not be that familiar with. So that also helped too. So getting that guidance from the methodologist was extremely important in creating this new survey.
Give us a sense of what you found and how is it different than the
Mhm.
previous surveys?
Yeah, so some very interesting findings here. So we've seen that maybe a shift in who's ordering or prescribing parental nutrition in the U.S. And so within the survey, we saw that dietitians actually were leading in terms of prescribing or ordering PN, followed by pharmacists, then by physicians and then nurse practitioners. And if you go back to the 2003 survey, primarily it was physicians that were ordering. So we've seen a change in practice. Yeah, I think the other thing that we've seen too, we've seen maybe a decrease in the number of nutrition support teams out there. So that may have, played a role in this as well. So that's one thing that we've seen is how things have changed in terms of ordering, prescribing. The other thing too is more people are outsourcing parental nutrition than they've done in previous years. So, and that's not uh, not unexpected because of the cost of compounding. Some facilities really, it's actually probably more cost effective for them to outsource the parental nutrition than do it in
And by,
house.
and by that you mean that that the orders are sent to an outside pharmacy and
Correct, right. There's an outside pharmacy that's licensed to do such, and they actually deliver to the facility or to the organization. They usually have, the technology, if you will, things like automated compounding devices and other things like that that are important for PN safety and can be quite costly for some facilities if they don't do a certain number or compound a certain number of parental nutrition bags. The other thing that we saw that was interesting is the increase in technology, which is good. We've seen in medicine an increase in EHR, electronic health record ordering, which is good. But initially, you didn't always see that with PN. Some people were still doing handwritten orders, and so now it's good to see that more people are doing this electronically. That's certainly a safer way, prevents the transcription errors. We've seen a greater increase in the use of automated compounding devices for PN, which is also another excellent tool. Software available there to make sure that everything is appropriate. I would say also the interfacing of the EHR to the automated compounding device or the ACD is another. We've seen an increase in that, and that's good. Certainly reduces the potential for transcription errors occurring. Increased smart pump use, barcode technology, all those things are safety things that need to be in place. And this survey actually showed an increase. So that was good to see that. So those are some, I think, areas of practice where we've seen some improvement. Also, I would also probably add filtering as well. Filtering of parental nutrition has, per the survey, has increased, which is also another positive move in terms of the PN arena. When you look at some things that were a little concerning, we haven't made some inroads in terms of how maybe electrolytes are ordered. So when you look at the adult population, stayed about the same from the 2011 survey. So that was a little disappointing because Aspen recommends that we order the electrolytes per salt. And so that really was unchanged from previous survey. In the adult population and the pediatric population, we actually saw an increase, which was good. So that was a little bit concerning. I think another thing too is that we did have the option to answer unsure. And so we saw a fairly significant percentage of these questions being answered as unsure. And so that may be because of some of the fragmented care that we have, depending on who maybe was, answering the survey, maybe didn't know that answer. So they were unsure, maybe filtering practices or how salts are ordered or anything like that. So it was a little concerning to see those unsure significant percentage and unsure. And I think maybe because we've seen maybe the lack of nutrition support and the fragmented care, unfortunately, that we're seeing in the PN process right now. But we did see some positive moves here within the survey, but I think also some opportunities as well.
Great. Just to clarify for those that are not aware, the recommendations since back before the previous survey have been that the electrolytes are ordered in their salt, which means that you order sodium chloride, you don't order a total amount of sodium and a total amount of chloride and similar. I also noticed that there still is a lot of ordering of macronutrients that is not consistent with the guidelines. Do you want to comment on that?
Yeah, because that's a great point there, Dr. Sears. So we at Aspen recommend amounts per day or amounts per kilogram per day in the pediatric neonatal population. So we're still seeing some people order per volume or percent overall. There has been some improvement there, but not where we want to be. And so there's obviously some room for and opportunities for improvement in that area too. So
Yeah.
some progress has been made, but more needs to be made in that area.
I noticed that the survey asked both per day and per total volume. Is that really significantly different?
It is. It's clearer per day because you're actually ordering like say for amino acids so many grams per day, and so when you look especially transition of care, it's very clear as to what the patient's getting, and you don't want that breakdown in transition of care for sure. As patients leave your facility to another facility or your facility to home, that order needs to be very clear as to what you're doing, and I think that's also why we want salts as well because that makes it very clear to everybody exactly what the patient has been getting in your facility.
Great. How about next steps? What should people take away from this and try to do on their own or in partnership with Aspen?
Absolutely. Yeah, I think there's some opportunities here for sure. When we look at we're not where we want to be in terms of ordering. We need to see some more standardization of the ordering process across the board for everyone. and hopefully working with other organizations, we can do that. And Aspen has done a really nice job of working with other organizations like Institute for Safe Medication Practices, for instance. We've teamed up on another number of things to make people aware. I would say also things like hang time for lipid emulsions. When we looked at that, it didn't necessarily meet the ASPEN guidelines, and we recommend if they're hung separately that the hang time not exceed 12 hours. And we saw a number, a fairly high percentage exceeding that 12 hours. And that's not only an ASPEN, but a CDC recommendation as well. I
And
think
that's
that's an
due to the
opportunity.
risk of bacterial overgrowth
Yeah,
in the
right. No doubt. Yeah, very, very much so. I think too, when you look at from a pharmacist standpoint, with the revised USP, United States Pharmacopoeia 797 chapter for compounding sterile products. In the new revision, parental nutrition is not denoted separately like it had done in previous chapters. So there's some confusion about beyond use dating and parental nutrition. Aspen still recommends 30 hours at room temperature and 9 days refrigerated. We're seeing some people interpret the new or revised USP 797 incorrectly. If you look at most people are putting in a parental nutrition category 2 for parental nutrition, and that would, if you look at that, that's only sterility. It says 4 days, but that's sterility, not stability. Now, USP does state that it's only sterility, it's within the chapter, but people are missing that point. And so they're interpreting that to be stability as well, but that's only sterility. So we've got some education to do there. So we can hope to continue to work with USP and other organizations too to be sure that everyone is clear on beyond use dating and parental nutrition and how that is now going to be incorporated within the new USP 797 chapter.
Great. What should individual people do when they know that the practice in their institution, for instance, doesn't follow the guidelines?
Yeah, I think that, of course, every institution is different. Some people have nutrition committees. Some people do things through maybe their pharmacy and therapeutics committee or maybe even their medical staff committee. I would think that it would be an important thing to bring the survey to your committee, to your overseeing body, and point out maybe some of the deficiencies or opportunities for your facility to improve and work through that process. Again, maybe through your pharmacy and therapeutics committee, you can look at, say, hang times of lipid emulsions and be sure that your policies and procedures all fall within the recommendations of guidelines that Aspen has published. I think that would be a really good start for folks. I mean, it is a medication, it's a high alert medication. So I think your P&T committee was very important. I think also having a physician champion with this is certainly important with institutions as well, because we don't have the teams like we used to back in previous years, and so we are seeing some of this fragmented care. And so I think that getting all those players involved, physicians, pharmacies, dietitian, nursing, really making sure everybody's on the same page and communicating however that best works within your facility if you don't have a formal team is very important.
And I completely agree. And I think that it is really important that individuals that have an interest in this or are involved in any way in the care of patients who receive nutrition support go to the appropriate committees, even if you're a first day dietitian or a seasoned or elder such as Phil and I. Those doors had better be opened, or you're not working in a place that I would want to be a patient in. And so make some noise and try and get their attention. I would also point out that organizations like the Joint Commission are aware of these guidelines, and so pointing out to your committee that they're not in compliance with them and that puts them at risk for being dinged is not a bad strategy. But even more important is the risk to the patients in terms of safety, and that these things have been designed with patient safety in mind.
Totally agree. It's really about the patient, and it's a very complex medication. I mean, it's anywhere from 30 to 40 components here. So one of the more complex medications that we use, unfortunately, not always seen as a medication, but it is a medication.
Yeah. You use the term high alert, and I just wanted people to know exactly what that means and what other things are high alert in comparison.
Yeah. So for instance, insulin is a really good example of a high alert medication. So it's a medication if used in error can do significant harm to a patient is what's considered a high alert medication. So
Right.
again, parental nutrition, if we don't use it correctly, can do significant harm, to a patient. even documented things like, the rate not being appropriate or confusing the lipid emulsion rate with a PN rate, for instance, could do harm to patients. So it's very important that we do consider it a medication and that we treat it as a high alert medication.
And chemotherapy is in that group, is it not?
Chemotherapy as well, correct.
Right. And just to help the listener understand why we think this is important, at Columbia University Medical Center, we were doing in the adult population between 20 and 30 PNs a day, and there was a very, very limited number of people who were credentialed to write these orders, and they included me and a fellow and a junior attending. We looked at all of the communications from the pharmacy and used that as a gold standard for errors in our ordering. And there were more than a couple a day that the pharmacy picked up that we had missed. So understand that this is a complex process that is really best carried out by people who are at least aware of the safe practices and the guidelines that are available. I will also put in a plug that Aspen every year does a parenteral nutrition ordering webinar, a series that is really quite worthwhile. And I highly recommend that anybody who's involved, even if it's only very occasionally, expose themselves to some of the issues so that they might provide the therapy more safely.
Those are great points. And also too, Aspen has developed competency tools for everything within the PM process, whether it be, ordering, compounding, order review, administration. So those are actually excellent papers and documents with checklists. So it can be part of your annual competency within your facility for those involved in the PM process, whether it be physician, pharmacist, nurse, dietitian. Those tools work for all the disciplines.
Most of these documents that we're referring to are available to the public at the Aspen website, which is nutritioncare.org. And they're certainly available for free if you become a member of Aspen, and can take advantage of all of the other educational opportunities that Aspen provides. Phil, anything else you'd like to add?
Just want to encourage those, if you've not seen the survey, please review this survey, review your own process within your facilities. And also for those of us who are Aspen members, we really need to kind of expand our outreach. So when you see things like this, be sure your colleagues are aware, even try to present these on a state level, state meetings. It's always important to get the word out because, not everybody's a member of Aspen. They may or may not be familiar with some of these practices, but I think anytime we can make these known within the healthcare family, I think that's very important. But other than that, it's been great being with you, Dr. Sears. I appreciate it. Always good to see you. And thanks again for your support.
It's my pleasure, and it's really great to see you, Phil. And thank you all for listening, and please do check out the article.